I'd like to introduce Dr. Mark Hallett. I first met Dr. Hallett through this organization when he asked me to give a talk on hemifacial spasm, and he's subsequently become a friend of mine, and I admire him and his work very much. He's had an extremely distinguished career in movement disorders. He's currently the chair of the Benign Essential Blepharospasm Research Foundation Medical Advisory Board and the chief of the Human Motor Control Section at the National Institutes of Neurological Disorders and Strokes at the NIH. He's been the president of the Movement Disorder Society and vice president of the Academy of Neurology. He's won just about every award you can win in his field, but he really continues to make terrific contributions, and I appreciate you taking the time to join us this weekend.
Well, thank you very much, Ray. I appreciate those very nice comments, and thank you for all your help with the organization. We're switching computers here, which will take a second. Okay, good. Right, so now I'm going to tell you about the pathophysiology of blepharospasm and also of photophobia. And the charge is to talk about the cause of blepharospasm, which is a difficult matter, but of course it is just a form of dystonia, as you heard from Dr. Jankovic. And in relation to the cause of diseases in general, that's getting to be actually a complicated problem. And in order to talk about it, we will deal with risk factors in epidemiology and sort of general causes as the first topic. The sort of general way of thinking about disease or phenotype, and by phenotype we mean what are the characteristics of a particular disorder or a particular disease such as blepharospasm. We think of them as being a combination of genetic factors and modifiers, and you can think of that then as a phenotype P equals G, genotype plus M, which are modifiers of various kinds. And it turns out that there are going to be probably multiple G's and multiple M's that will relate to any particular disorder, and it's this sort of complex combination of all those factors that lead to a particular problem. So we'll talk about them as relates to blepharospasm. And we have to use these as sort of hints to give us some cause, and to a certain extent we know about the hints, but we don't know exactly what they mean and how you can incorporate them into thinking about it. So first of all, the average age of onset is 59 of blepharospasm. It can be of various ages, but it is the oldest age of onset of any of the focal dystonias on average. It's also the case that women tend to be much more affected than men, 2.3 times more than men. So not only age is relevant, but also gender is relevant. It's the case also that disorders of the anterior segment of the eye, such as dry eye, blepharitis, are relatively common. So there may be a factor of that is relevant in the etiology. And then there's this interesting inverse association with smoking and coffee drinking, although the effect of smoking can be explained largely by coffee drinking. And what that means is that people that drink more coffee are less likely to develop blepharospasm. Now, this is interestingly also the case in Parkinson's disease. So people that drink more coffee are less likely to get Parkinson's disease. And why this is the case is not clear. People sort of speculate about it, but we don't really know exactly why that's the situation. Now, one of the things that people always ask, and I don't know the answer to this at all, is that once you get blepharospasm, if you drink more coffee, will that be helpful? And we don't know the answer to that question. I think that's something that is worth knowing, and I think someday we should do a study of that. Someone should do a study of that. But in any event, these are interesting factors that we need to learn about more. Now, another point, and Dr. Jankovic mentioned this in his talk to a certain extent about spread of focal dystonia from one body part to another, but patients who develop blepharospasm first are more likely to develop focal dystonias than those patients that have another type of focal dystonia first. So, for example, if you have cervical dystonia or spasmodic dysphonia, you are less likely to spread to others than if you have blepharospasm. And another point is that most of that spread occurs in the first few years. Again, as Dr. Jankovic mentioned, within 5 years or so, you have a sense about how much spread there is going to be. Now, how do abnormal genes cause disease? And this is one of the things that's happening in medicine at the moment. There's what you might call a revolution in terms of understanding the role of genes in relation to causing disease. And I think that one can think about genes in two different ways. One is that the gene is a very strong causative gene, so-called Mendelian trait, that if you have the gene, this is necessary to get that particular illness. And something like Huntington's disease or DYT1 dystonia, a form of childhood onset generalized dystonia, are examples of that. Now, the gene is necessary but not sufficient. So in order to get Oppenheim's dystonia, DYT1 dystonia, you need that gene, but you may not, even if you have the gene, you may not get it. So there are other factors as well. It goes back to what I was saying, that it's multiple G's and multiple M's that are going to be relevant for any disease. And in addition to that gene, you do need something else, but you do need that gene. There are other situations in which the genes are only risk genes. They seem to increase the risk a little bit, but they're not necessary for the disease. So, for example, in Alzheimer's disease, if you have a gene for what's called ApoE4, then you're more likely to get Alzheimer's disease, but it's not necessary. It just increases the risk of it. So genes can have variable influence, very strong or just relatively weak. Now, what do we know about the genes in relation to blepharospasm? We don't really know very much at the present time. It'll be valuable to find them, but we don't really know. We do know in some families there are a variety of focal dystonias, and in other families, a number of patients all have blepharospasm. So there are probably at least two different types of genetic influence, one that seems to cause relatively pure blepharospasm, another type of gene that just predisposes to different types of focal dystonias in general. Now, we do know a little bit that there was an association with a abnormality in the DYT1 gene in some patients from Italy, but we couldn't confirm that in U.S. patients. The U.S. patients are those of you who have participated in NIH genetic studies in the past. And this is another result from, again, you guys who were participating in some of the genetic studies. There is one polymorphism in the here called the TOR1A gene, which is also the DYT1 gene, that influences the risk of spread of blepharospasm. So it's a risk gene influencing spread, but not the influencing whether you develop blepharospasm in the first place. So there's a little bit of genetic information, but we don't know a whole lot yet. So where are we now? We haven't found any formal Mendelian genes, ones that have very strong influence trying to produce blepharospasm. There's an attempt to find risk genes. Risk genes are sought for in association studies. You may hear the term a gene-wide association study or a GWAS, and GWASs or association studies are being done looking for risk genes. They're in progress. And there are new techniques now called whole exome analysis and even whole genome analysis. They are again looking for Mendelian genes, and they are in progress, but there are no clear results as yet. So people are actively working in the genetic field, but we don't have so much information yet. In terms of environmental factors, we talked about local eye irritation, including dry eye. You'll be hearing more about that later. Dryness of the eye will increase the gain of the blink reflex. We know that eye disorders are epidemiologically relevant, so there's something going on there that clearly is important. So at the moment then, G, the influence seems to be small at the moment, but it almost certainly is in fact required. At least some risk genes are going to be required. And the external modifiers are going to be big, but only small factors have been identified so far. So we really have a lot more work to do in this regard to understand exactly what's happening. Now, in terms of the anatomy, where are there problems in the brain that lead to blepharospasm? And again, we have a lot of mysteries in this regard. There have been only a few neuropathological studies, and basically this is one of the more recent in this regard, where the brains of a few patients who've had blepharospasm have been carefully looked at in the microscope. Nothing has been found. So the brains generally appear to be pretty good in this regard. Sort of a puzzle. Something is the matter somewhere, but it's not obvious what the situation is. There have been a number of MRI studies looking at brains, and one would think that that would be something that would be helpful in this regard. And most of the MRI studies that have been published find something. The problem is that every MRI study that's been done has had a different result. And it's been very difficult to figure out what that means. It's been extremely confusing. I'll just show you 3 different studies. I'll just show you the pictures very quickly. I'm not going to go into the details. Here's one, there's another one, and here's another one. This one happens to be ours from the National Institutes of Health. They all have different results, and I don't know what to make of that now. So I've just gotten very confused by the MRI studies. Now, the pathophysiology of blepharospasm, I think, is a little bit clearer in terms of the types of physiological derangements that lead to the closing of the eyes. This has been studied for a number of years, and I think we do understand a number of features there. And there are at least 3 types of physiological abnormalities. One is a loss of inhibition in the brain. And when there's a loss of inhibition, that means that there is a tendency for excessive contraction. And if there's a balance between excitation of muscle and inhibition of muscle, and if there's a loss of the inhibition, then there tends to be too much muscle contraction. And that is a sort of a fundamental feature of all types of dystonia. So that's one of the central abnormalities. There is also a mild abnormality of sensory function. You already heard from Dr. Jankovic that sensory influences can change the amount of blepharospasm, and that is one of the features of the sensory side. And there's also an abnormality of brain plasticity. That is the capability of the brain to change in certain circumstances. Let me just illustrate the deficient inhibition as has been shown in a number of different studies. And one of the best ways of looking at this is looking at the blink reflex. The blink reflex looks at the way that the eye responds to different stimuli. The easiest way of looking at it is looking at it with a shock to the supraorbital nerve. So if you give a little shock to the supraorbital nerve, the eyes tend to close in a blink. And this is what happens here. If you look at part B, which is called normal, is looking at a patient that doesn't, a person that doesn't have blepharospasm. This is the EMG, the muscle activity of the right eye. This is the muscle activity of the left eye, and this response here is the blink. So you give a little shock and you get a blink. Now if you do a second shock, 200 milliseconds, a fifth of a second later, the amount of blinking is less. And this is called inhibition of the second blink compared to the first blink. Now if you have a patient that has blepharospasm, here's the first blink and here's the second blink. So that inhibition that was present in the normal subject is not present in the person that has blepharospasm. Suggests an increased excitability, that is, in fact, a loss of inhibition in the blinking of patients that have blepharospasm. So this is an example of this loss of inhibition that leads to excessive contraction. So the current concept of the pathophysiology then is that blepharospasm is a hyperexcitability of eyelid closure resulting from a combination of a permissive substrate like loss of inhibition, an environmental factor like one that increases the gain of eyelid closure, giving rise to an aberrant plastic change in the central nervous system control mechanisms of eyelid closure. And that's the sort of way of putting a number of these different factors together to understand where blepharospasm comes from. Now I'm going to say some words now about the pathophysiology of photophobia, which is another feature of patients that have blepharospasm. So light causes pain and discomfort, and that is probably more accurately called oculodynia. Photophobia just means fear of the light. Oculodynia refers to pain in the eye relating to the light. In addition to the pain and discomfort, light also causes blinking and spasm of eyelid closure. Now, the pathophysiology is really unknown, but there are some recent very good ideas that people have been talking about. There's a bit of excitement about this, in fact, and let me tell you what we know about it at the present time. So if you think about the way that light interacts in the eye, the ordinary types of photoreceptors, those cells that receive light that have been known for a long time, are the cones and the rods in the retina. And the cones are blue, green, and red cones. They're the ones that see in bright light and can identify colors. And the rods are those that see more in the dark and are responsible sort of for black and white type observations. And they send their information through the optic nerve to the brain in order to see. But there are also a set of cells which are just in a sense recently been identified that contain melanopsin, and they're at a slightly different part of the retina that are sitting over here, and these cells are sometimes called intrinsically photosensitive retinal ganglion cells. They contain melanopsin, and they have a number of interesting roles, sending their information to various parts of the brain for various things. One of the things that they are responsible for is circadian entrainment, that is taking the day-light cycle and deciding when you sleep and wake. So they are sort of responsible for keeping you entrained in the daily cycle of sleeping and waking. They may have some role in pupillary light response, and they may be related to photophobia because some of the information from these cells get into parts of the thalamus, and where the thalamus relates to somatic sensation and pain. So some of that information can also potentially produce pain. Now, let's think about the colors of light that these cells are responsive to, and let me remind you about electromagnetic radiation and the different parts of this. We can see with the eye only a very small part of this whole spectrum. So very short rays, very short wavelengths are gamma rays, and then there's X-rays, and there's ultraviolet. We see this visible light part, which is this very tiny part here expanded, and then longer wavelengths are infrared and radio waves. So the little part of visible light that we can see with our eye goes from about 400 nanometers to 700 nanometers, and these are the colors that are in fact related to that. And then if you look at the rods and cones and these melanopsin cells, these are the photosensitivity of those. So these are the red cones, the green cones, and the blue cones. These are the melanopsin and the rods, and they're in this range here. This is actually the range of blue. So while these are called the blue cones, it's actually blueness is more seen in the range of melanopsin and the rods than they are in the blue cones. The blue cones are a little bit further down the line there. Now, another thing that's interesting about these melanopsin cells is that they have been identified now not only in the retina, but also in the iris, the colored part of the front of the eye that gives you blue eyes or brown eyes. And there are melanopsin cells there, and there are also possibly some melanopsin cells in the cornea itself. You could read about those corneal melanopsin cells in the recent issue of the Blepharospasm newsletter that comes out. We have given an investigator by the name of David Copenhagen a grant to look at this, and he gives a synopsis of some of the work that he's doing in the recent Blepharospasm newsletter. So he's found some of these in the cornea as well, but they're in the iris, and those go directly into the sensory system, into the fifth nerve trigeminal ganglion and into the thalamus, where they can join with the other information in the thalamus and perhaps cause pain. Now, interestingly, there was a study using PET a number of years ago trying to see if there was any difference in those patients that have photophobia and those without photophobia. And one of the differences that was identified was in the thalamus. So that those patients that have a lot of photophobia have more activity in the thalamus than those without photophobia. And this is where the information from these melanopsin cells is going, and perhaps that is a clue that this is where photophobia is in fact mediated. Now, then the other aspect of this, even before a lot of this was known, is that photophobia can be treated with glasses. And what do these glasses of various kinds do? Well, dark glasses can reduce the amount of light coming in. There's a question, which we'll get into in a moment, about reducing a specific color of light, and the issue there is specifically blue light. If you block blue light, will that be helpful? And the blocking of blue light seems to make sense in relation to the melanopsin cells that we're talking about that seem to respond specifically in the blue wavelength. Now, glasses also reduce environmental stimuli such as airflow and dust. So glasses have another role in addition to light. They do play several different roles in perhaps the advantage for decreasing photophobia. Now, there's been a great deal of interest in this, in the so-called FL41 lens, because this particular lens tends to block blue light, and I will show you a little more detail about that in a moment. The question is a specific frequency of light more noxious than others? And if it is in fact blue light, then these FL41 might be particularly good. So let me show you the wavelengths of different light in terms of the amount of transmission that you can see with the different lenses. So let's look first. This is the wavelength on this axis, and this is the amount of transmission of light on this axis. And if you look at a gray dark glass, that's this gray curve here, and you can see that it blocks a lot of light. You only get about 50% transmission. This is the 50% transmission line in most wavelengths, but it transmits relatively more blue than other wavelengths. Where if you look at the FL41, it has a wave shape like this, so it tends to block blue slightly more than the other wavelengths. Now that isn't specific to FL41. You can have a rose-colored glass, which is not FL41. That also tends to block blue more than the other colors. And of course, if you're blocking blue, then you have a representation a little more of red. That's why the FL41s look sort of reddish or pinkish, because you're blocking the blue, therefore it looks more red. So this is the logic of the FL41, or rose-colored, because you tend to block blue more than the others, and it may be relevant because of the melanopsin and the melanopsin types of inputs that I was describing to you earlier. Now there has been one study comparing gray glasses and FL41 in terms of patient receptivity and feeling of benefit, and the FL41s seem to be better than gray, but honestly I have never believed this study, because almost all of the patients participating in it were ones that had been using the FL41 glasses already, so we're, I think, already biased in that regard. So I don't think there's any strong evidence at the moment for FL41 being better than gray, although logically you can see where there may be some benefit more to the FL41s. So I think the needs for the future are pretty clear. We need more research activities, both in understanding the etiology of blepharospasm and photophobia. Genetics, I think, in relation to what we're thinking about in terms of blepharospasm is clearly important, and there is this great revolution going on in medicine that I described earlier with respect to genetics, and I think that as we learn more about genetics here, we will understand a lot more about different diseases, including blepharospasm. So that's where we are with our understanding of these situations at the moment. Thank you very much, and I'll look forward to your